Hello, this is Landmesser from Charité University Hospital in Berlin, and it's really a great pleasure to have a roundtable discussion here at the EuroPCR meeting this year together with Professor David Hildick-Smith from Brighton in the UK, a very well-known interventional cardiologist, and with Professor Stephan Windecker from the University Hospital in Bern. And the topic we are discussing today is advances in the field of left atrial appendix closure. In this year, we have seen the consensus statement from both associations, the ERCPI and the ERA, on I think how clinical left atrial appendix closure has improved and has really become part of the management programs of patients with atrial fibrillation. And at this meeting, this EuroPCR meeting, we have, I think, very interesting new data regarding the clinical outcomes of left atrial appendix closure to NOAC therapy, at least with observational studies. And we will also have in our roundtable discussion an insight about the new trial, the Catalyst trial, that specifically looks at the question how left atrial appendix closure compares to NOAC therapy in patients with atrial fibrillation. And it's my great pleasure now to hand over to Professor David Hildick-Smith, who will introduce us on the clinical need in the field of patients with atrial fibrillation and his background or his view on what the recent data we have seen in that area mean for clinical practice today. And we will then also discuss, of course, later what we will learn for the future from ongoing interesting studies. David.
Thanks so much, Ulf. Yes, so I suppose the first thing to say about this is with AF, there are so many patients who actually can't have or don't have appropriate treatment to try and reduce their risk of stroke. I mean, the risk of stroke is 5 times increased with atrial fibrillation, and treatment is needed. Now, a lot of patients can't have anticoagulation, and that's for a variety of reasons. Sometimes it's because of bleeding. Sometimes it's because of other contraindications. Sometimes it's because of lifestyle choices. A lot of the patients actually, when they take these anticoagulants, aren't terribly compliant in taking them either every day or ending up having an appropriate INR. Now, that's not so important for the NOACs, but exactly where the sweet spot lies if patients forget some doses is also not entirely clear. So there are a lot of patients who have atrial fibrillation who don't get appropriate treatment. Now, the alternative here is a left atrial appendage occluder. It's a one-off treatment. Okay, it might be relatively expensive, but over time, the financial burden related to daily NOAC does, after a while, even out. And patients don't like taking tablets, and very many of them will prefer conceptually the idea of a single treatment, one-off, rather than lifelong treatment with anticoagulants. So there are a great number of patients, a high proportion of patients with AF who should be having some treatment to prevent their risk of stroke who actually aren't.
Thank you very much, Dave. I think this was a great introduction to this field and also illustrating indeed the clinical need and potential advantages of alternative strategies of stroke prevention in these patients. And I think you alluded to the problem of bleeding, and of course these patients are difficult often to convince to continue with anticoagulation therapy. But you also mentioned the need of compliance, and that is, of course, as you say, mentioned in the one-time procedure, a potential advantage. And we are very happy to be in a situation where we get now indeed increasing data from randomized trials in the field of left atrial appendix closure. And Stephan will now introduce us to some new data presented at the EuroPCR regarding a randomized clinical trial, and will also give us an outlook on a summary of interesting presentation of observational data comparing left atrial appendix closure with NOAC therapy in patients with atrial fibrillation. Stephan.
Thank you, Ulf. Thank you for the opportunity to present two studies that have been presented during the hotline session of this year's Euro PCR. And one is the roll-in cohort of the Amulet IDE trial. So the Amulet IDE trial is actually the first head-to-head trial comparing the Amplatzer Amulet device with the Watchman device in patients with atrial fibrillation. Now, the overall trial is a large-scale clinical endpoint trial that enrolls more than 1,800 patients. This is not what I'm going to talk about. I'm going to talk about the roll-in cohort that consisted of 201 patients that were exclusively treated in centers in the United States, where the device has not FDA approval at this point in time, and therefore the operators enrolling into the Amulet IDE trial have had no previous experience. Now, what is important in this roll-in cohort to understand is that they had exactly the same inclusion criteria as in the main Amulet IDE trial, and that they also followed or were evaluated for the same endpoints. And there was a primary endpoint that describes the mechanism of action, that is device closure, as assessed by transesophageal echocardiography at 45 days. Then there's a primary safety endpoint, which is a composite of procedure-related complications, all-cause mortality, and major bleeding at 12 months. And then there's a primary effectiveness endpoint of ischemic stroke and systemic embolism, also assessed at 1 year. Now, the patient population is that of an elderly with a mean age of 74 years and a mean CHED-SVAS score of 4.6 and NASBLAT score of 3.3. And what was interesting is that the vast majority of patients were actually treated with dual antiplatelet therapy, more than 80% of patients, which then after 3 months was discontinued and changed to aspirin monotherapy in the vast majority of patients. Now, as it relates to the findings, as it relates to the mechanism of action, the peri-device leak, as defined as less than 5 millimeters at 45 days, was achieved in 99% of patients. So, a very high technical success rate. And if we look at the clinical safety endpoints, it's notable that all-cause mortality was 4.5% at 1 year, that procedural complications amounted in total to 3.5%, and that major bleeding was observed in non-procedural related in 11.9% of patients. And interesting also, the composite of ischemic stroke and systemic embolism at 1 year was 2.0%, keeping in mind that the CHED-SVAS score was 4.6%. So all in all, a very high implant success of 99%, and notable, as mentioned during my introduction, that these results were achieved in individual or by operators that had first-time exposure to the Amulet device. Now, the second very interesting presentation was given by Jens Erik Nielsen Kurz from Denmark. And what they did was a propensity score match comparison of left atrial appendage occlusion with non-vitamin K oral anticoagulants. And as it relates to the comparison of the Amulet device with NOACs, this is actually one of the first comparisons. So it's a non-randomized comparison, but they used a very good methodology to perform this comparison. And basically, they compared 1,078 patients that were enrolled in the Amulet observational prospective registry, and then compared it to 18,570 patients with atrial fibrillation that were recorded within the nationwide Danish National Patient Registry. And after propensity score matching for basically age, CHED-SVAS score, and NASBLAT score, they arrived at 1,071 patients that underwent LAA occlusion and 1,184 patients that were treated with a NOAC and were followed for a period of over 3 years. Now, what's very interesting is the clinical outcomes, and they reported this as event rates per 100 patient years, so events per 100 patient years. And if you look at the composite of ischemic stroke, major bleeding, and mortality, then this was 14.5% for the LAA occlusion as compared to 25.7% for the NOACs. And if you look just at ischemic stroke, it was 2.1% for the LAA occlusion, and it was 1.9% for the NOAC use. And major bleeding was a difference of 6.0% for LAA occlusion as compared to 10.0% for those that use NOACs. And perhaps most interestingly was a difference in mortality, which amounted to 8% in the LAA occlusion group as compared to 15.3% in the NOAC group. So if you take this in perspective and express it as relative risk reduction, then there was basically a similar outcome as it relates to ischemic stroke, but there was a 38% relative risk reduction in terms of major bleeding and 47% risk reduction in mortality. So very interesting findings from these two studies.
Stephan, thank you so much for summarizing this really interesting new data for us, highlighting both the, I think, increasing safety of LAA closure, even in centers that are starting a new program. And I think some very provocative data from a propensity matched analysis that I think I would like to give to David now to discuss, in particular, I think this provocative reduction in mortality of almost half in mortality in these patients as suggested by this observational study. And maybe you could comment on how you interpret this data and whether they are relevant for your clinical practice already.
Yes, so probably two things to say from the data that Stephan very nicely summarized there. The first one is related to the roll-in for the IDE trial. If I can just make a point about that, I think it is impressive that despite the fact that these were centers that were not necessarily at all experienced, that's why they were doing roll-in cases, the procedural success was 99%, and the complete seal of the left atrial appendage, which is of course the intention, was also up around 99%. So very consistent with what we saw in the global registry. So I think, you know, that augurs very well for the experience with this device. The second data that Stephan presented very nicely was about the Danish study. And I think this is really provocative data because it showed not just that you get a reduced bleeding rate with left atrial appendage occluders, but also, unexpectedly, that there's a significant difference in death rate. Now, that is something which is, I'm sure, not what Jens Erik was necessarily expecting, but does in fact chime with what was found in the Protect AF study at 5 years. And so that does raise the suggestion that it may be a real finding, and that occlusion of the left atrial appendage offers a mortality benefit in excess of the benefit related purely to bleeding risk. Of course, with bleeding risk, you expect a benefit because that's the whole reason you're having the left atrial appendage occluded done, so that you don't have to take daily anticoagulants and run the risk of bleeding. But when you add on top of that the potential for a mortality benefit, that is very enticing and extremely provocative. And I think it will be really interesting to see in the dedicated randomized trials whether that same finding is seen.
David, thank you very much. I think, as you mentioned, these data are really provocative, but they are indeed in line with what we have as far as now available from randomized studies. Both the Protect AF and studies showed after 4 years a reduction in mortality, and also the meta-analysis of both trials, Protect AF and Prevail, suggested a reduced mortality that is now seen in this propensity matched analysis. So it clearly stimulates us to look further in that direction, and might actually, if the data would hold true in further randomized trials, it might really change the landscape of management of atrial substantially. And I think one of the reasons why clinicians, some clinicians have been reluctant towards LAA closure is that we need more data from randomized studies. And I think Stephan will now introduce us to a very important new randomized study that is started called the Catalyst trial, that really will compare left atrial appendix closure with NOAC treatment, and this time actually in all patients NOAC eligible. The discussion we had now about the propensity matched analysis for patients with very high bleeding risk, and also their randomized trials are ongoing. But the trial that Stephan presents to us now is really extending in a more broader patient population of with atrial fibrillation. And Stephan, I'm very much looking forward to you presenting us where the trial stands and what we can expect there.
Sure, thank you, Ulf. As mentioned by David and yourself, it's important that we build on observational evidence and try to reproduce it in prospective randomized clinical trials. And in that context, there is the Catalyst trial that is sponsored by Abbott, and will compare the LAA occlusion with the Amulet occluder versus a medical treatment with non-vitamin K oral vitamin K antagonists. And on the slide, you see the trial design. So basically, it addresses patients with atrial fibrillation that are eligible for oral anticoagulation and do have a CHA2DS2-VASc score of 3 and more. And this trial will be a clinical endpoint trial that enrolls more than 2,600 patients that are then randomly allocated 1-to-1. And this trial will assess 3 primary endpoints. The first one addresses efficacy, and that is a composite of ischemic stroke, systemic embolism, and cardiovascular mortality. And the goal here is to show non-inferiority of LAA occlusion with the Amulet device as compared to the NOAC therapy. The second primary endpoint will be major or clinically relevant non-major bleeding. Again, this aims to show non-inferiority. And the third one is major or clinically relevant non-major bleeding, but excluding procedure-related events. That is, after successful LAA occlusion, you just will look at the bleeding events long-term, and here it will look for superiority. Now, the trial design is finalized, and it's expected to start enrollment in July of 2020, with the completion hopefully be done sometime in 2024.
Stephan, thank you so much for introducing us to this very important new trial. We have, I think, in our roundtable discussion covered some very new, interesting data that are available from the EuroPCR 2020 meeting. We have seen data from the Amulet IDE roll-in study that suggests indeed that centers that have even not an established LAA closure program can start this procedure with a rather low paraprocedural event rate. And I think we have this year also had the, I think, very recommended consensus statement from ERA and ERPCI, which also helps, I think, in establishing LAA closure programs, and also stresses the role of imaging, also by, for example, cardiac CT that can be used to plan better these procedures like we do in other cardiovascular interventions routinely now, and maybe this can indeed help to make it even safer, this procedure. And I think we have discussed with both David and Stephan very provocative data from a propensity matched analysis suggesting reduced mortality of LAA closure compared to NOAC therapy. I think we still don't understand all the background of this observation, but it's remarkable. It's consistent with the randomized trial evidence that we have available, and therefore makes us even more excited to look at the ongoing randomized studies, both in the patients with a high bleeding risk and the catalyzed trial that will expand potentially the indications for LAA closure also to NOAC eligible patients in the future, and is therefore, I think, very important for the landscape of management of atrial fibrillation. I thank you very much, David and Stephan, for giving us this important new insights from EuroPCR, from the new trials presented, and I think also your take on the data from this exciting propensity matched analysis. And thank you very much for joining us in this webinar, and you will be also having the chance to look at these original data actually on the website of the EuroPCR meeting. And we hope that you enjoyed the discussion here with us. Thank you very much.
Thank you.